Hi there, I'm Janine van Hoofd and I'm a gastroenterologist in the Leiden University Medical Center. And today we're going to make an Anderson production. And that means actually that we are going to show you how to nicely interrogate the more difficult part of the pancreas, among others the neck and the uncinate, and also really the tip of the tail, as these are always difficult parts to surely visualize, and they are needed if you want to do an EUS FNA or FNB. And so now I'm going to hand over to my colleague Dr. Anderson.
Now one quick word on semantics and language in EUS. When you move the large wheel down, the tip goes down, then you engage the mucosal wall. Large wheel away from you, tip goes up, you disengage from the mucosal wall, and it's sometimes handy when you want to view the liver hilum from the duodenal position. Considering rotation, when you have the wheel up a little bit towards you, you can exo-rotate, so we call that counterclockwise, and endo-rotate, we call that clockwise. This is the quickest way to communicate in EUS.
Well, before we start, it's always a good thing to know which equipment you're using. In this case, we're using a Fujifilm Arietta 850 EUS processor. It is top-notch and yields excellent image quality. And we're using that in combination with a Fujifilm linear EUS echo endoscope. It's a EG 580 UT echo endoscope with a 3.8 millimeters working channel. Now, on entering, always be careful that you don't end up in a hiatal hernia. So what I usually do is first introduce the linear echo endoscope into the corpus of the stomach and then search for the aorta and pull back a little bit. And when I found the aorta, I look for station 1, this the celiac trunk that comes off from the aorta, which you can see here quite nicely. Then you jump over the celiac trunk, and there you can find the pancreas. So first I've zoomed in a little bit to the superficial mode, where the scanning radius is maximal 4 centimeters. And then we scan through the pancreas by turning the echo endoscope over the shaft of the endoscope in a clockwise fashion. And while rotating the endoscope over the axis of the shaft of the endoscope, pulling back a little bit, we can backtrack the pancreatic duct towards the pancreatic tail. Here you see the left kidney coming into view. We move even further. Now I have to rotate my wrist a little bit to the right, so in endo-rotation to just follow the pancreatic tail even a little bit more. And here the pancreatic tail ends just in the splenic hilum. So here you have the spleen. When I rotate counterclockwise, you have the left kidney, and here the tail of the pancreas. Now, as you can see, if I make this movement of a counterclockwise rotation of the echo endoscope, you can track the pancreatic duct even just so far into the neck of the pancreas. Sometimes you do have a lesion which is a little bit more down in the pancreatic neck and you can't follow it. There is a little workaround for this. What you then can do is release the large wheel, so put the tip a little bit upwards, release the large wheel of the endoscope, go over the pancreas, so literally you're positioning the echo endoscope more over the angulus of the stomach, and then you re-engage the echo endoscope by pushing the large wheel down, so you re-engage the mucosal wall, then you torque the echo endoscope clockwise, and then you have re-engaged the pancreas. Now, what you now see here is the pancreatic duct more in a linear fashion. It does not go down, but it goes more superficial. And now you can track it here over the confluence and track it even further towards the pancreatic head. And in some instances, you can even appreciate the common bile duct here in the deep, where it joins with the pancreatic duct. So here you have the pancreatic duct, and down below you have the common bile duct. Sometimes the station-wise approach doesn't really work. So you have found the aorta, you find the celiac trunk branching off, but you just can't find the pancreas. Well, there is a workaround for that. First, look for the left liver lobe. That is usually easy to find because the left liver has a lot of heterogeneous structures. Look for one of the portal veins. The portal veins are the veins that have duplex signal and have a hyperechogenic rim around them. Now, do a backtrack of these portal veins towards the hilum of the liver. So you're tracking them back to the center of the liver, and there is the central portal vein. Now, the portal vein usually points up towards the 11 o'clock position. So if I rotate even further in a clockwise position with the echo endoscope, you now see the portal vein pointing to the 11 o'clock position. And now I push the scope a little bit forward and follow the portal vein. And when you do that, you end up into the confluence, and then the pancreas will be just here above the portal vein with the pancreatic duct just adjacent to the portal vein. So that is a very neat trick in case you can't find the pancreas in a very steatotic patient or after distal pancreatectomy, for example. Now, one of my favorite tricks to find the papilla and to have a better overview of the duodenum is to infuse the duodenum with several syringes of water. So here I'm injecting with in total 3 syringes of water of 50 cc's, and I've also given the patient 10 milligrams of Buscopan so that the water stays in place. You see the horizontal part of the duodenum here down below, and when I pull back on the echo endoscope, you see the head of the pancreas coming into view quite nicely. Now, usually when I want to find the papilla, I move a little bit away from the head of the patient, so I rotated the head of the endoscope with the knobs away, pointing to the adjacent wall. And now I gently rotate my body back and forth until I see these linear structures coming into view. This one is the pancreatic duct, and if I want to find the common bile duct, I rotate a little bit more counterclockwise, and that small structure above is the common bile duct. And when I rotate back clockwise, it's the pancreatic duct. You have them both in view here. So above, common bile duct, down below, pancreatic duct. Now, this is a very useful trick when you have to evaluate, for example, an ampullary lesion. Now, one of the most challenging stations to view is the uncinate of the pancreas, especially when you have a lesion in the uncinate of the pancreas that you have to puncture. It may be hard to reach and sometimes impossible to reach from the stomach position. So maybe you will be able to view the lesion, but if you have to reach it, that's a different story. Sometimes you have to do that from the horizontal part of the pancreas. Now, what you can then do is the following. Here you see in the endoendoscopic view the common bile duct and the pancreatic duct, and you see still some water in the duodenum. When I rotate clockwise, you have the superior mesenteric vein and artery. When I rotate counterclockwise, you see the aorta running alongside the pancreas. And now I'm disengaging from the ampulla and inserting the echo endoscope in. Usually you'll need around 1 meter of insertion. And I try to keep here the pancreatic duct into view. So try to keep that in your echo endoscopic view. Insert, insert, insert. and now you have a long scope position. So you see basically the pancreatic head upside down, opposite to what we just saw, and now you have the confluence right here at the 9 o'clock position, and where you follow the pancreatic duct, your uncinate process will be right here, located under the level of the transducer. This may be a challenging position and sometimes not feasible under conscious sedation, so you will need propofol in that case. It takes a couple of attempts, but still keep in mind, try to follow the pancreatic duct, keep it into view when inserting the echo endoscope, and then you have the uncinate of the uncinate process of the pancreas right under your transducer. Now, for one final advice considering tissue acquisition, if you have a patient with a pancreatic adenocarcinoma or another pancreatic lesion that you want to FNA or FNB, take into consideration that you take the shortest route in order to avoid post-puncture pancreatitis. Usually that is only 3% chance, but you want to take the shortest route. In this case, we have a patient with a lesion in a pancreatic head. We are now viewing the pancreas from the stomach. Here you have the pancreatic duct, and we're going now down into the neck, going up and over the pancreas. And I reconnect with the mucosa again, and here you see a lesion here in the pancreatic head. Now, it is possible to do EUS FNA from the stomach, but you would have to traverse a considerable amount of pancreatic tissue, and you have the risk of hitting any crossing vessels. So always view the lesion from different stations. So we're now going to the duodenal bulb and see if we have a better connection with the tumor there. Now we're in the duodenal bulb, and here we have the common bile duct, and I can track it towards the hilum, and I can track it towards the pancreatic head. And here we have the tumor again, but now we have very few intervening vessels. Even with fine flow, there are some crossing vessels, but now we have a safer trajectory for EUS FNA. And this is from the duodenum. You see here the water in the duodenum. This is the pancreatic head, and the entire pancreatic head is changed by tumorous tissue. So this may also be an adequate site for needle puncturing. You see here with fine flow that there are traversing vessels, but no large vessels. And there is no vital normal pancreas that you would traverse with a needle. So in conclusion, always assess the pancreas from different stations in order to assess the best place for EUS needle puncture.